Hello, my name is Marissa Elmendorf, and I will be presenting case study number 84 on psoriasis. Psoriasis is an inflammatory skin disease. It is characterized by red, itchy, scaly patches that are mostly observed on the knees, elbows, trunk, and scalp. Psoriasis is a chronic long-term disease which appears in cycles and flare-ups that can last for weeks or months. The primary cause of psoriasis is uncertain, although approximately 1/3 of people diagnosed with the disease have a hereditary factor. It is thought that activated T lymphocytes, mainly CD4 positive helper cells, produce chemical messengers that stimulate abnormal growth of keratinocytes and dermal blood vessels. Skin trauma is a common factor in triggering flare-ups. How psoriasis develops. In psoriasis, the life cycle of the skin cells accelerates, leading to buildup of dead cells on the surface of the epidermis. Psoriasis is characterized by increased epidermal cell turnover, epidermal thickening, which is known as hyperkeratosis, and in this diagram we can visualize normal skin versus the skin of a patient with psoriasis. Types of psoriasis. The most common type is plaque-type psoriasis. Lesions can occur anywhere on the skin and are most frequently observed on the elbows, knees, and scalp. The primary lesions are thick, have red plaques with a silvery scale, which we can visualize in this picture of the patient's elbow. The lesions observed in plaque psoriasis vary in size and shape, and there could be excoriation, thickening, and oozing from the lesions. Another type of psoriasis is guttate psoriasis, which usually occurs in children and young adults. It often develops suddenly because of a streptococcal infection. Usually it appears as teardrop or small and round lesions, which are pink to salmon-colored scaly lesions. It is mostly observed on the upper trunk and extremities, and here we can visualize an example of this type of psoriasis on the back. A third type of psoriasis is pustular psoriasis. This kind of psoriasis is characterized by papules or plaques with pustules. The pustules can present as white, pus-filled, painful bumps, and the skin around them may be red and inflamed. The pus in the pustules is not contagious. The different types of pustular psoriasis are localized pustular psoriasis, generalized pustular psoriasis, and acropustulosis. Localized pustular psoriasis is usually limited to palms of the hands and soles of the feet. Generalized pustular psoriasis affects large areas of the body, and acropustulosis, which is when symptoms affect only the fingertips or the tips of the toes. This photo shows localized pustular psoriasis on the hand. A rare form of psoriasis is called erythrodermic psoriasis. It affects all body surfaces, including the hands, feet, nails, trunk, and extremities. It is characterized by severe redness and discoloration. Skin shedding occurs as we can see in the picture provided. Pain and itching associated with this type of psoriasis can be severe. This type of psoriasis can be life-threatening as it can disrupt the body's temperature and the natural fluid and electrolyte balance. A psoriasis flare-up can be triggered by certain medications, starting or stopping medications, stress, infections, injury to the skin, and tobacco or alcohol use. A diagnosis of psoriasis is made by the healthcare provider asking questions, a physical exam, a biopsy may be performed to help determine the type of psoriasis and will help in ruling out any other diagnosis. The healthcare provider may complete a psoriasis area and severity score, also known as a PASI score. The PASI reference values are as follows. Redness, induration, and scaling are rated on a scale from 0 to 4, and the percent of skin involved is rated from 0 to 100%. These are calculated on the head, arms, trunk, and legs. Psoriasis has no cure. The goal of treatment is to suppress the signs and symptoms of the disease. There are topical and systemic treatment options. Topical agents are used first if less than 5% of the body surface is involved. Topical treatments include emollients, cherolytic agents, Cartol products, anthralin, and corticosteroids. Systemic treatments include phototherapy, photochemotherapy, methotrexate, retinoids, corticosteroids, and cyclosporin. Combination therapies that are patient-specific are the most effective treatments, and often rotating various treatment is beneficial in decreasing side effects of one specific treatment. Sunlight has a positive effect. A new treatment for psoriasis is Skyrizi. It was approved by the FDA in 2019 and is an interleukin-23 inhibitor. It can be utilized to treat moderate to severe plaque-type psoriasis. It is available as a treatment option for patients who are prospects for systemic or phototherapy. The clinical trials have shown high rates of skin clearance, 90% of skin clearance in the first year, and the majority of patients receiving full skin clearance. This treatment is available via injection. 4 doses a year are needed. 2 initial doses are required. This treatment option can be administered in a medical office or by the patient at home after education has been provided on how to administer. A new study aimed to identify if the use of systemic immunosuppressants in people with psoriasis may have a greater risk factor for adverse outcomes of COVID-19. The aim of the study was to characterize the course of COVID-19 in psoriasis patients. The study included 374 clinician-reported patients from 25 countries. 348 patients with psoriasis fully recovered, and that was 93% of patients. This study found that in the large international series of patients with psoriasis and COVID-19, the use of biologics was associated with a reduced risk of adverse COVID-19 outcome when compared with the risk associated with the use of non-biological systemic agents. Further data and research are required before any changes can be made. So case study number 84, history of present illness. KB is a 40-year-old white female with a 5-year history of psoriasis. She has scheduled an appointment with her dermatologist due to another relapse of psoriasis. This is her 3rd flare-up since a definitive diagnosis was made. This outbreak of plaque psoriasis is generalized and involves large regions on the arms, legs, elbows, knees, abdomen, scalp, and groin. Her past medical history. KB suffered a major episode of rheumatic fever at age 14 that has led to complications associated with rheumatic heart disease. She has no other chronic medical conditions and no other acute medical illness. Family history. Her father is alive and well. Her mother recently passed away from ovarian cancer after a long illness. She has 3 sisters and 2 brothers, except for a younger sister who has also recently developed signs of heart disease from a bout of rheumatic fever many years ago. All of her siblings are well. There is no family history of psoriasis or immune disease. Social history. KB has been a purchasing agent for a large national insurance company for 13 years. She smokes 4 to 5 cigarettes a day, uses alcohol only socially, doesn't use illicit drugs, is married, has 1 son, age 15 in high school. There have been increasing tensions and anxiety at work recently because rumors have been circulating about possible downsizing and layoffs. KB has also been stressed at home due to bitter words exchanged between her father and siblings. Medication. She is taking ibuprofen for occasional headaches and Rolaids for occasional heartburn. Allergies. She has no known drug allergies, but was counseled by her PCP about stomach cramps after eating lettuce. Additional history. The patient's skin itches terribly despite using non-medicated moisturizer several times a day. She has been feeling nervous and stressed lately because of tensions at work, in the family, and due to the recent death of her mother. The physical exam reveals the following findings. General. KB is a white female who is alert, mildly anxious, but in no apparent distress. Her vital signs are as follows. Blood pressure is 145/90. Her pulse is 75, respiratory rate is 14, temperature is 98.5, her height is 5'2", and she weighs 165 pounds. Her skin has confluent plaque-type psoriasis with extensive lesions on the patient's upper and lower extremities, scalp, abdomen, and groin. Approximately 40% of total body surface area is involved. Lesions are bright red in color with sharply defined borders, except where confluent and are covered with loose, silvery white scales. No pustules or vesicles present. Lesions on the arms, legs, and abdomen are consistent with scratching. HENT. Extensively scaly lesions on the scalp. Perla, fundi normal, tympanic membranes intact, pharynx clear. Chest is clear to auscultation. Her heart regular rate and rhythm. With no rubs or gallops, a murmur can be distinctly heard. Abdomen. Positive bowel sounds, soft and non-tender, with no masses, extensively scaly lesions and excoriations on skin. Genitalia are normal. She deferred her rectal exam. Breasts have no masses, dimpling, discharge, or discoloration. Musculoskeletal extremities. No swelling, warmth, redness, or tenderness of joints. Psoriatic lesions on elbows, knees, forearms, and calves. Yellow spots and nail plates on fingers. Peripheral pulses 2 positive throughout. She's alert and oriented ×3. Her cranial nerves are intact, and her gait is steady. Here are the patient's laboratory blood tests. We will review abnormal blood test results on an upcoming slide. Question number 2. What has possibly triggered this patient's current outbreak of psoriasis? Factors that could have triggered the psoriasis outbreaks are: her mother recently passed away from ovarian cancer after battling a long illness. Increased tension and anxiety at work because of rumors of downsizing and layoffs. Stress at home because of bitter words between her family members, and she smokes 4 to 5 cigarettes a day, drinks alcohol socially. Increased stress, tobacco, and alcohol products can trigger psoriasis flare-ups. Question number 3. Why should a topical medication not be considered an option for this patient? A topical medication shouldn't be considered for the patient because of the amount of body surface area that is involved in the psoriasis outbreak. The psoriasis is generalized and involves large regions on the arms, legs, elbows, knees, abdomen, scalp, and groin. Approximately 40% of the total body surface is involved. The patient was previously treated with a topical medication when lesions were small and confined to small regions on her elbows and legs. Question number 4. What is the preferred treatment of this patient? The preferred treatment for this patient is phototherapy with UVB, as it is a widely utilized treatment which has fewer side effects than other treatment options that are available. Question number 5. Other than widespread plaques and scales, does this patient have any abnormal clinical signs or laboratory tests that are consistent with the diagnosis of psoriasis? KB reports that her skin itches terribly despite using a non-medicated moisture several times a day. She also has lesions on her arms, legs, and abdomen that are consistent with scratching. It is reported that she has yellow spots on the nail plates of her fingers. These are all clinical signs of the diagnosis of psoriasis. Question 6. From the physical exam and laboratory test, identify 7 clinical manifestations unrelated to psoriasis that should concern the PCP. This patient's blood pressure is 145/90, indicating elevated blood pressure. She is 5 feet 2 inches tall, weighing 165 pounds, making her BMI 30.2, which indicates obesity. Upon assessment of her heart, a murmur can be heard. Abnormal lab findings that should concern the PCP are that her calcium is low, hemoglobin and hematocrit are low, red blood cell counts are also low. She reports taking ibuprofen for headaches and Rolaids for heartburn. More thorough questioning of the patient should be completed regarding the answers to these questions. In conclusion, psoriasis is a common skin disease. It is characterized by red, itchy, scaly patches and plaques. Several factors can trigger an outbreak. Initial diagnosis and treatment are essential to manage this disease. Treatment options depend on the type and severity of the psoriasis. New treatment options show promising results. At this time, there is no cure for psoriasis. These are my references. Thank you.